Government and health experts have warned that the coming weeks will see a rise in COVID-19 infections. No doubt, government's reopening of the economy is also contributing to the spike we've seen in the last few days. But for a broad perspective on the times that we're in and how to deal with it, we're joined now by Dr. Kerrin Begg, who's a public health specialist based at the University of the Western Cape. The Western Cape, of course, the hardest hit area in the country. A very good evening to you, Dr. Begg, and thank you so much for speaking to us. So we mentioned the fact that the Western Cape is obviously the epicenter and has been for a while. But how would you categorize the time that we're in? It's been said that we are peaking. So how do we understand, put into context, this rapid transmission that we're seeing?
So it's part of the area of pandemic that we were expecting. We managed to buy ourselves some time as we went into lockdown in terms of preparation for the rapid hospitalizations. We have had then a regional difference with the Western Cape escalating significantly earlier than other provinces. But the reality is that Gauteng and Eastern Cape are starting to escalate now in similar fashion. In fact, if you look at the steepness of the curve of Gauteng and Eastern Cape, it's actually even steeper at the moment than Western Cape was at the time, which is very worrying. So, cases are always a function of what we test. So we need to be aware that that's always an indication of the count that we do is based on what testing we do. And of course, the Western Cape earlier this month changed the testing strategy. So we're not comparing apples with apples in June versus what we compared with in May, because non-serious cases are essentially not getting tested at the moment, but having a presumptive diagnosis of COVID if they meet the criteria. So those are all things that we need to take cognizance of. What's always concerning is to look at deaths and hospital numbers. And of course, hospital numbers also reflect that hospital beds are full. In the Western Cape now, they've started opening up the field hospitals, and so the CTICC in particular is slowly starting to increase in numbers. So those are all things that are concerning. We were expecting it, but it nevertheless is a concerning time for us.
And I want you to weigh in on this because we will look at South Africa uniquely, but it's important to also juxtapose that against the international experience that we've seen. A Swedish epidemiologist was very critical of the WHO, saying that they were overstating the health risk, putting the country onto a list of rapid transmissions without looking at the nuances of the country's response. So would this be the case in South Africa as well? As you mentioned, the Eastern Cape and Gauteng are also quickly climbing in numbers. But how should the provinces then apply the nuances, the uniqueness of their own situation in this next phase?
I think that So whilst there are nuances, I think that, what we realize is that being a little bit behind the curve of the rest of the world means that we can learn from what others have done, both what they've done poorly and what they've done well. And certainly one of the challenges for us is what we can refer to as quarantine fatigue and epidemic fatigue, that people are tired of staying home, and especially when they don't really see it affecting their own personal lives. So the fear factor kept people home in the early days. Now, unless you've had people around you and close to you that have been positive and particularly severely affected, people are tired, and so the risks are so much higher because they're starting to aggregate and congregate and socialize again. And that's probably the worst thing that we can do right now. This is a disease of congregation and aggregation. We give the virus legs. The virus can't move without us as human beings moving and connecting up with other people. So the worst thing that we can do right now is opening up and socializing as usual. What we really need to be doing is the economy needs to get going. but we need to go to work and come back home and try to engage with other people as little as possible. Where we do engage with other people, make sure that we're wearing our masks, washing hands, and keeping physical distance.
So, Dr. Begg, let me ask this. There has been this whole argument of screening versus testing, because it's important for us to understand when exactly do you need medical attention, and there's also too much information on what you should do, how you should self-isolate, and whether or not you need to be quarantined. So how do we approach that particular dimension?
So remember that the testing involves a range of different steps, and I think that that's what people have perhaps not understood. The testing starts at the point of screening, which is symptoms. Unfortunately, this disease is like a chameleon, and as we learn more about it, we realize that there are so many other manifestations of the way in which people present, because it's not entirely a respiratory disease anymore as we'd first understood. It's in fact a thromboembolic disease. That means that it's a disease of the blood vessels with inflammation, and so the organ that gets most affected or commonly affected is the lungs, but there are so many other ways that it can present as well. And so screening is a relatively blunt instrument of indicating who might or might not have disease. We then refer people for testing, which means, and the start of that is sampling. So that means, as you see in your visuals, those swabs that get taken of the nasopharynx, so it gets put into the nose and into the mouth to take the specimen, that then goes to the lab, and the actual laboratory test gets taken, and then we get a result. So all of that together contributes to testing. Screening is but one part of the broader testing process. And of course, if we don't test, then it means we don't diagnose positive cases. So one of the early concerns was that we were probably not testing sufficiently. If you look at our death numbers, which are today last night sitting at 2,340, and when we look at that, we know that our cases, our symptomatic cases, are about 1%, our deaths are about 1% of our symptomatic cases. That means that although we are now recording, as of last night, about 125,000 cases, we actually have about 2.3 million symptomatic cases in the country. And if we take it a conservative estimate that only 50% of our cases are symptomatic and 50% are asymptomatic, we know that worldwide up to 3/4 of our cases can be asymptomatic. So if we do it conservatively, we're looking at, based on our deaths alone, at 4.5 to 4.8 million cases in the country. But we're only detecting 125,000 cases. So in one sense, it's good news, and that for the vast majority, those cases are likely to be asymptomatic. Many of us may well have had the disease and not ever been diagnosed. But on the other hand, it does mean that it makes it very difficult to control the epidemic, because so many people are pretty much walking around with COVID unknowingly.
So, Dr. Begg, just before we go, I mean, you did mention, it was the first thing we spoke about, where we are, the peak. But there seems to be this thing that people want to pinpoint the exact day or period within which we're going to see this peak. You're talking about asymptomatism at the moment, and there's been the concept that because people are asymptomatic, they're going around viral shedding, and we don't know it. So when exactly then do we know that this is actually the peak? And does that matter, or should, as you advise, people just observe social distancing, physical distancing?
Correct. So the reality is that we will only know when the peak happened after the fact. The peak will come, and we'll only really be able to say a week or two later that we've plateaued sufficiently, we've tested, our testing strategy didn't change during that time. There weren't any other factors that could have impacted the peak. So we'll only know after the fact. We certainly know that the active cases in the Western Cape are plateauing. And so that gives us some hint that we are starting to head towards the peak now, but we won't know until after the fact. But the reality is, as I say, that we have diagnosed very few of the actual cases that are likely to be present in the country. And therefore, what we all need to be doing, unfortunately, is living on islands and staying at home and making sure that we have as little contact with other people as possible. If we do need to go out to work, that we simply go out, have as little contact either through a multiple of factors, including masking, physical distancing, hand washing, hand sanitizing, all of those golden rules, making sure that you stay home, whatever the minorest of symptoms are, whatever you have as a minor sniffle, a cough, a fever, a sense of malaise and tiredness, any of those things, just simply stay home and rather stay safe.
Right.
Stay away from other people as far as you can, and then we can finally start to slow this virus down and later head back to normality.
Dr. Begg, thank you so much for your time and your insights. Public health specialist at UCT, Dr. Kerrin Begg. So we will continue the conversation later on after 7, looking at it in detail, the actual active cases, the death rate, and also break it down by gender as well as age to find out exactly what the exact nature of the cluster of infections is as well, and whether that is also accelerating and at which rate. Community health workers in Port Elizabeth say they have